Want to welcome everyone. So I'm Mike Mugavero, Director. I want to thank everyone for joining us. This is our second session in the UAB Learning Health System Month. So March is Learning Health System Month. Last Tuesday, we kicked it off with Chuck Friedman from Michigan. Really excited to have Dr. Russell Rothman here with us from Vanderbilt. And the next 3 Tuesdays from noon to 1, please mark your calendars, have a great slate of speakers focusing more locally at UAB. Folks doing some great work within the health system. And I see Dr. Tony Jones has joined. He's been our key partner from UAB Medicine in this endeavor with the core, as well as with community and population health sciences and preventive medicine, hospital medicine, CCTS. So a number of partners, too many to name on the call. And also in the interest of time and a little bit of a late start and Russell having a lot of slides, it's really such a joy to welcome Dr. Russell Rothman to join us and present today on the journey at Vanderbilt. So Dr. Rothman is a professor of medicine and pediatrics and health policy, the Ingram Professor of Integrative and Population Health, and a senior vice president for population health and public health at Vanderbilt University Medical Center. He's the director of the Institute for Medicine and Public Health and the chief of internal medicine and pediatrics in that section. And it's really amazing. So just on a personal note, I graduated from Vanderbilt Medical School in 1999. And at the time, there was very little going on in the areas of population health and kind of health services and outcomes. There was some great work in hospital epi and at the VA, but over the last 2 decades, just the emergence and growth of pop health, epi, and the Institute has just been remarkable. And Russell has been instrumental in that with a number of other folks. So really appreciate Russell taking some time to kind of come and talk with us and share that journey as a partner and a peer just 3 hours to the north in Nashville. So Russell, really, we welcome you. We'll look forward to hosting you back in Birmingham, hopefully in the not too distant future when we spring forward with vaccination, but really thrilled you could join us in this UAB LHS month and share some of your experiences and perspectives. So welcome and thank you.
Yeah, Mike, thank you very much. It's a pleasure to be with everyone today and to see some old friends, at least virtually on Zoom today. I've had some great collaborations and connections with UAB over the years and have known you, Mike, and Andrea now for close to 20 years. So it's really fun to be participating in this and to share some of our story at Vanderbilt about how we've been trying to address issues related to population health and also build out a learning health system. And I'm going to give a very broad overview and touch on several different projects and areas that we've done that broadly apply to the concept of the learning health system and more broadly to population health research as well. So just a few disclosures of current funding support and previous consulting. And I think people are aware that we have a lot of significant health disparities in this country, particularly in the southern United States, where we are in Tennessee and Alabama. This is some data that was in JAMA a few years ago, just looking at anticipated life expectancy of people born in 2014. You can see that just depending on what county you live in, there can be as much as a 20-year difference in life expectancy. And, you know, while some of this may be related to genetics, a lot of it is clearly related to social and behavioral and environmental determinants of health. And, you know, this issue has only been further exemplified with the COVID epidemic over the past year, where we've seen even more issues with challenges with access and health disparities and other issues. So there's many different reasons why we have challenges in providing high quality of care in the United States. We know as much as 50% of recommended care is often not delivered to our patients, or our patients don't achieve those quality metrics. And there's a complex array of issues that really contribute to that, including issues at the health system level, at the community level, as well as at the patient and provider level. And on top of that, I think there's been growing recognition about these broader issues that impact health. And so we are seeing a change in how healthcare is delivered and a change in the market, in the regulatory environment, and the delivery of healthcare. So we are seeing a move. We're in a lot of a hybrid situation right now between still traditional health insurance and newer models of reimbursement, but we are seeing a move from fragmented care to more coordinated care, from reimbursement that was more based on individual events to focusing on bundles of care or population management, for reimbursement tied to quality metrics and population health. And an increase on patient-centered medical homes and accountable care organizations. So a lot of this change in the market is driving a need for more research to understand how to better deliver care at the individual and population level in ways that really improve the value of care delivered. So improve quality at good cost. And so population health has really become a more important area over this last decade or so, especially with the changes in reimbursement and the broader understanding of the importance of social and behavioral determinants and how they impact on health. And so population health has been defined as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. Population health is not just the overall health of a population, but also includes the distribution of health and the health of individuals. So when we think about population health, it's really a lot of different issues that you have to take into consideration that may impact on an individual or a population's health. Much more issues than we maybe traditionally considered when we were thinking just about the individual patient who came into our office or came into the hospital. So we need to think about, the care that we're delivering within our health system, individual behavior, social and environmental issues that might impact on health, physical environment issues that may impact on health, and genetic issues. And, some studies have suggested that the genetic component may only represent 10 to 15% of a person's health outcomes, or predicting a person's health outcomes. So when we're thinking about population health, we really need to take into account a lot of issues that may be contributing to health and health outcomes. And this also applies as we try to do research and design improved ways to improve care. So one model for thinking about this is the broader socio-ecological model. And when we think about how health is impacting an individual or a population, we need to think about what is going on at the individual level in terms of the individual's own personal characteristics, their behaviors, knowledge, attitudes, beliefs, as well as their genetics, but also their interpersonal factors, how they're interacting with friends, families, social networks, organizational factors, community factors, policy level issues, and even global issues that may impact upon their health. So again, as we're thinking about how to improve health, both at the individual level and at the population level, we really need to think about all of these complex factors that may come into play. We can't always address all of these factors in a single study, but it's important that we keep these issues in mind and in context, because they often are important drivers of health. And many people feel a bit overwhelmed by seeing something like this, right? How do we possibly tackle all of these different things that drive health? But I'm going to show you some examples where we have tackled issues to try to improve health that cut across these spaces, not always all at once, but we always need to keep all of these issues in mind. If you want to look at it from a research paradigm, a lot of people are familiar with this translational paradigm that a lot of our CTSAs and the NIH sort of endorse. And I would say a lot of what we do on the research side is really in this distal T3 and T4 spaces, where we're doing research to understand how do we translate evidence into practice? How do we do the effectiveness studies and really try to understand how is care best delivered in practice? How do we do the implementation research and really scale it out to figure out how to improve care, not just at one location, but across a health system or across a region or across a community? And specific to population health right now, there's a lot of health system redesign going on in terms of building out these accountable care organizations, clinically integrated networks, building out population health offices, a lot of leveraging of big data to try to drive how we deliver care, a lot of targeted programs on chronic disease management, high utilizers, patient-centered medical homes. There's really not a lot of evidence right now, at least strong, rigorous evidence on the best ways to deliver care at the population level. So I think there are a lot of important opportunities as we build out our learning health systems to really do the research and inform our healthcare systems about how should they best be delivering care, what works and what doesn't work. And when things work, how do we scale them out in ways that are evidence-based and then proven to still work once scaling has occurred. So again, a lot of this we put into the context of what many people refer to as a learning health system, but you'll see here I've called the learning and innovation health community, and I'll explain what I mean by that. So a traditional learning health system, you see evidence gaps, you try to design improvements, you implement it, you evaluate, you adjust, and once you feel you have a good process working, you try to disseminate it across your health system or across a multitude of healthcare facilities in your system. And you continuously do this process to try to bring out improved delivery of care across your system. I like to refer to it as not just a learning health system, but an innovation system, because I think a lot of the research that we do isn't just about taking existing evidence and figuring out how to get that evidence to work in a delivery model, but it's also about how do we create innovative approaches to care and test those innovative approaches to care before we scale them out. And then I also don't like calling it a learning health system, but I rather like calling it a learning health community, because as health systems, we really need to take into account not just what's going on in our health system, but what's going on in the communities around us. And if we want to improve care, we need to engage our community. So we need to include our relevant stakeholders, our patients, their families, their community organizations, because remember from that socioecological model that I showed, healthcare is really driven by all of those factors. So if we're really trying to build out learning health system models, we're really building learning health communities that spread across those spaces. So I'm going to share with you some specific examples of projects we do that have touched on various aspects of addressing population health, and have also tried to build these within the context of being a learning health system or a learning health community. The first series of studies I'm going to show relate to work that we've specifically done trying to address issues of health literacy and numeracy. So really getting at some of the social and behavioral determinants of health. So some of you may be aware about issues of health literacy and numeracy. It's estimated that over 90 million Americans have only basic or below basic literacy skills. 110 million have only basic or below basic numeracy or math skills. Average American reads at the 8th grade level. And we also have over 20 million Americans with limited English proficiency, what we used to refer to as English as a second language. And so we did a series of studies really demonstrating that health literacy was important in predicting how well people understand information about their health and how to take care of their health, and even related to health outcomes. So, we did some studies showing that people with low health literacy or numeracy, which remember is very common, struggle to understand things like understanding food labels, portion size estimation, reading over-the-counter cold and cough medicines, understanding how to make baby formula for their children, reading thermometers. And also in diabetes, we found that a lot of people with low literacy or numeracy have difficulty understanding a lot of the skills we ask them to do when taking care of their diabetes. So over 25% of patients we tested had trouble interpreting their blood sugar meters. Over 40% couldn't show us how to calculate how many carbohydrates they were eating if they ate a bag of chips or drank a bottle of soda. Over 30% couldn't show us how to dose their insulin directly. And these underlying literacy skills were linked to their knowledge of diabetes, their behaviors associated with caring with their diabetes, and even their blood sugar control. And we found these underlying literacy issues were important even after taking other factors into consideration, like people's education level, their years of diabetes, and other factors. And so we designed a series of interventions to try to address these literacy issues when caring for our patients with diabetes. The first study we did was actually in North Carolina years ago now. We took over 200 patients with type 2 diabetes. We gave them all an initial education session with a clinical pharmacist, and then we randomized them either to usual care with their primary care physician within our clinics or to an intensive disease management intervention, and we followed them for a year. And those that were in our intervention really received a comprehensive intervention that included diabetes education and some diabetes medication management, but a lot of it was very sensitive to literacy. So we reduced jargon, we used plain language, we provided low literacy educational materials as part of our intervention. And at the end of the study, we found that those that got our comprehensive disease management intervention that not only was addressing clinical care issues, but were addressing some of the social determinants, including things like literacy level, access to care, transportation issues. We were able to significantly improve blood sugar control, blood pressure control, getting them on aspirin, and to some degree improve their cholesterol control, although not quite statistically significant. When we stratified out our results by literacy status of our patients and looked at their blood sugar control, we found that those patients who had high literacy, who participated in our intervention, did a little bit better than those patients who were in the control arm. But among those patients with low literacy, those patients who got our intervention actually did a lot better. And we really felt like we were taking these patients who formerly were falling through the cracks of our system, and by addressing these literacy issues, we were able to empower them and help them with their self-management, and they improved accordingly. So we followed this up with a second series of randomized trials trying to look more closely at the numeracy or math issues that a lot of our patients with diabetes have to navigate. And we designed a whole toolkit of materials to use when talking with our patients, with a lot of low literacy text, simplification of math skills, and color coding to try to better explain things, step-by-step instructions. In this study, we randomized patients to either get this literacy sensitive intervention or to continue with usual care, either in primary care or in their diabetes clinics. And we did this in North Carolina and also at Vanderbilt and at the VA. So we did it across several different clinical sites. And again, we found at the end of the intervention part of this study that by providing this intensive focus on literacy and especially math issues, we were able to more significantly improve blood sugar control in those that got the intervention. And then finally, we did another randomized trial trying to look more closely about how we educate patients with diabetes about their nutrition in particular, and what the role was of doing certified diabetes education for our diabetes patients. So we took 150 patients with diabetes at our clinics at Vanderbilt, embedded in our primary care and endocrine clinics, and we randomized them either to get usual care with their provider and 3 control contacts just based on basic public health education versus receiving usual care with their providers plus 3 visits with an RD certified diabetes educator who focused on teaching them a complex skill of carbohydrate counting. And then the third arm, they got that usual care plus the RD CDE, but rather than trying to teach them the complexities of carbohydrate counting, they just gave them a very simple approach called the plate method. So again, in one arm, they were taught how to read carbohydrates from nutrition labels and how to calculate their carbohydrate intake. And in the other one, we took a much simpler approach where we said, make half your plate vegetables and free foods, make a quarter of your plate protein, and make a quarter of your plate carbs, and don't pile the plate too high. And at the end of this study, first of all, we found that patients who got certified diabetes education had significant improvement in their blood sugar control compared to the control patients. But also when we stratified out the results by people's underlying math skills, we find that among the carb counting group, those who had very high numeracy skills had good improvement in their blood sugar control, but those who had low numeracy skills did not do as well. They struggled with the more complex nature of learning how to carb count. And among the plate method approach, which was a simpler approach, both our high and low numeracy patients did better. So the simpler education approach really seemed to work better for all of our patients. So this, again, is a study that's really helping us understand how do we better deliver care within our clinics and move away from sort of how routine care might be delivered to really try to address some important social determinants of health. And a lot of this work has contributed to some guidelines by the American Diabetes Association, but also has helped to inform our own clinical care within Vanderbilt, both in our adult and pediatric diabetes clinics, as well as our primary care clinics. And we did try to scale this out to our public health departments. So we partnered with the Tennessee Department of Health and did a cluster randomized trial with 10 state primary care clinics in the Middle Tennessee region. We recruited 400 patients into this study from these 10 primary care clinics. These clinics serve a very underserved population. Over 90% of these patients have no health insurance at all. And similar to the prior studies, we tried to teach at 5 of the clinics the providers in how to improve their health communication skills and using our literacy sensitive toolkit in providing care for the patients. But at the end of this study, while we found improvement in blood sugar in both arms, we did not show that our communication intervention was significantly better than sort of the standard of care education that was done in the 5 other clinics. So why did we fail to find more significant improvement in the health communication intervention arm in this study compared to the other studies? Well, again, I think it comes back to the socioecological model that I showed before. While we were able to address some of the communication issues at the point of care, we were not able to address a lot of the challenges that these very underserved patients were facing. A lot of them had huge rates of food insufficiency, huge access issues, challenges getting medication. We had people in and out of jail while they were in the study, huge issues with family stressors. So, again, this just points to the importance. You can't always address all of those issues, but if you're not aware of them and trying to address them in some of these population projects, you're going to be challenged to find positive results. We're currently doing some pediatric studies across multiple sites, Vanderbilt, NYU, UNC, University of Miami, and a new study with Stanford and Duke as well. We're training our pediatric residents in how they communicate to families with kids age 0 to 2 to try to prevent those kids from becoming overweight, because 26% of toddlers in the US are overweight or obese. And in our pediatric resident clinics, up to 50% of the kids that we see are overweight or obese by age 2 to 5. So I don't have time to go into this study today, but it's just another example where we've embedded our research into our clinical environment, trying to train our providers in how they improve their care delivery. Okay, so I want to switch gears and talk specifically about our learning health system platform, which we've built over the last 5 to 6 years, leveraging our CTSA. And this is a project with resources from our CTSA as well as from the medical center that is really helping to embed clinical trials directly into our health system to try to understand what works and what doesn't work, and then see if we can scale it out to care. We really try to identify very pragmatic clinical trials that we can embed into the health system and do fairly rapidly in 1 to 2 years with minimal disruption to usual care. Really something where we're doing often comparative effectiveness between 2 different approaches to care to find out what works better. We leverage a lot of our EHR and informatics to randomize patients to different types of care and to collect patient data so that we can do these studies with minimal interruption to flow of care and with minimal cost. So typically, people bring a project to us, either from the health system or from investigators, and we have a series of resources that help to design the study through our platform. We do studio sessions where we give the investigators and health system leaders input on how to design the study. We help with the protocol customization and endpoint selection. We provide informatics support, regulatory support, and other resource support to really help embed these trials. And then if they're successful, we help with the implementation phase as well. So this takes a huge team of people to really make this work. So we have engaged people from across the institution to really operate this platform. So we have people from operations, from the hospital, from nursing, our ambulatory pharmacy. We have people from our CTSA leadership, and then we have research leadership that all come together at regular intervals to design and implement these studies. And it takes a huge team. So we have operational expertise from nursing, education, quality, scientific and research expertise, and community engagement expertise that come into play for various projects as well. And as I mentioned, that also includes biostat support, informatics support, as well as some basic operational support. So an investigator or the health system can come up with a study idea. They can go to our website express interest in that. It goes through an administrative review. We bring it to a studio session or workshop where we start to hone the idea down, turns into a one-pager, comes to our executive committee for a review. If we approve the study, we then allocate resources to help the study move forward into the full design and study conduct phase, and then ultimately the implementation phase. So we have had over 90 project inquiries come through since we started. We've done 82 of these learning health system workshops, 23 further consultations to help groups, 21 deeper studio sessions. And so far to date, we have 25 active projects going on and 11 that have been completed. The average study length is a little under a year. And you can see on here a lot of the different types of studies that are either in the planning stage or have already been completed. These all have acronyms, so it's hard to tell what they are, but I can tell you, I will show you a few of the examples of the types of studies that we're doing. So these are a couple of the completed big studies. Well, let me go back because I don't want you to think it's all just these huge, JAMA level RCTs, because some of them are smaller studies. So, we do have some studies like looking at what's the role of post-discharge phone calls. How do we decide who gets EKG monitoring when they get admitted to the hospital? What's the role of having an automatic physical therapy consult on patients when they come out from surgery? What's the role of having a psychiatric eval system put into place for patients that are having challenges with staff on the ward? So, we have all sorts of questions that have come through that we've been able to implement, but some of them have been pretty large studies. So I'm going to go into some detail about the SMART and SALT ED studies, which are two studies looking at the role of the best kind of IV fluids for patients in the hospital. I mentioned we did a pretty basic phone call study looking at what's the role of post-discharge phone calls, where we did not find that they made a difference in reducing readmission or in patient satisfaction. And then, another example was one that we did a few years ago, where we randomized our units to chlorhexidine or not, and did not find that chlorhexidine was superior to soap and water, which saved us a lot of money when we started getting the chlorhexidine washing out of the units. So I'm going to focus on the SMART and SALT ED studies. And this debate has been going on for years. As an internist, of course, I always gave normal saline in the hospital, and I was very disappointed with these results that have shown a superiority to balanced crystalloids, which I thought only the surgeons prescribed because they thought they were special. And so, but here we have the data. So we actually wanted to look, what is the role of giving IV fluid that's saline versus balanced crystalloids? And they actually did two different pragmatic trials, one in intensive care units and one in the emergency room. So it was a crossover cluster randomized trial where basically a unit for a month would give only saline, and then the next month they would give only balanced crystalloids. And this went on for 6 to 12 months. And then we looked at the outcomes of the patients who got saline versus those who got balanced crystalloids. And then we did a similar approach in the emergency room, where at least on entry to the ER, they only got balanced fluid crystalloids versus saline until they got, admitted to the floor, usually 3 days later, because our ED is always full. But they mainly got one or the other. And the primary outcome in the ICU study was looking at a 30-day outcome, looking at major adverse kidney events. In the SALT ED study, it was looking more at reducing hospital stay, but the secondary outcome was the same MAKE 30 outcome. And so again, we for the SMART trial, which was the ICU trial, we had a total of 15,000 patients admitted to our 5 ICUs over the time that this study was done. And depending on what month it was and what unit they were in, they either got saline or they got balanced crystalloid. And then we were able to analyze the results at the end of the study. And so we did find, not a huge absolute risk reduction, but we did find an improvement in patients who got balanced crystalloids in the ICU compared to getting normal saline. And we found similar results for that secondary outcome of the MAKE 30 for patients who were getting their fluids in the ED on their way to being admitted. So based on this data, we really felt, and particularly in the ICUs, that it was time to declare that balanced crystalloid was superior to saline for our health system. So we then had to move to the implementation phase of how do we actually get this done. There are some tricks to this because you can sort of have some control over the computer systems and also what's actually available in the cabinet to driving some of what people prescribe. But I'll show you some of the issues that came up as we tried to implement this across the health system. So first of all, so you can see what was going on just in our MICU, where once the study started, the SMART trial, it's every other month. So you can see it switching every other month between, everybody pretty much getting crystalloid or everybody getting saline. And then the EPIC came out, and we were able to drive some of the decision making with EPIC and see some reduction. We published the results. Actually, I should say people here knew the results. So we started to see some reduction after we shared the results locally. We published the results that helped us get things down a little bit further. We were not as successful as this in the SICU as we were, or in some of the other units as we were in the MICU. Actually, we were good in the MICU. So let me just show you the next slide. So this actually shows the implementation across the hospital, across the different wards of the hospital, what's going on in terms of trying to get balanced crystalloid going over saline. So, the study results were published here. This is going down in time from November of 2018 at the top to May of 2019 at the bottom. So you can see this first dashed line is when the studies were published in the New England Journal. And you can see there are some early adopters, if you will, including our critical care units, which at least are more in yellow and green. And there are some groups that are still using the regular saline, including our GI endoscopy lab. So we're tracking this and we're seeing this. And so then we said, oh, something is going on here in GI. They are not adopting this balanced crystalloid. So we went and we met with them and we found that there was an issue in their sort of standard order sets that they were using in EPIC, and we got them to change that out. And so all of a sudden we were able to take it from red to green just by a few simple changes. And then, similarly here, we were able to identify some other issues with sort of standard order sets where saline was still sneaking in to sort of get more pervasive prescribing of LR and other balanced crystalloids. So, it really does take, this is the importance of designing these studies, first of all, with the health system on the front end, so that they're going to buy into the results that you have and are going to help you with the implementation activities on the back end. And then second, once you get the results, you can't just publish them in the New England Journal and assume that that is sufficient. You really need a process for observation, for quality assessment, quality improvement, implementation science, if you will, to really make sure that you have strategies in place to continue to monitor and see the scale out over time. All right, so I'm very conscientious of time. This is just a project we did with over 115 primary care and specialty clinics on the outpatient side, really helping them to measure quality, do quality improvement, and become patient-centered medical homes to really improve value-based care in the outpatient setting. This was done with funding from CMS. We engaged over 4,000 clinicians. This is really on like that T5 part of the translational diagram where we're even beyond research and we're really much more into the implementation of phase. We have good evidence about quality of care. How do we help clinics close their evidence gaps? All right, finally, for just a few minutes, I'm going to touch on our STAR Clinical Research Network, which is part of a large national network known as PCORNet. Our network includes Vanderbilt, the Vanderbilt Health Affiliated Network, Meharry, Duke, UNC, Wake Forest Health Sciences, and Mayo. We like to joke that the biggest success of our project is we got Duke and UNC on the same grant together. But seriously, it's been a great collaboration, and across these health systems, we have electronic health record data on over 12 million patients. And again, this allows us to really engage in research both regionally across the southern United States, but also nationally with the rest of PCORNet, particularly to do comparative effectiveness research and we have data on over 12 million patients, and you can see the breakdown by our various health systems. It's quite a large amount of electronic health record data that we have standardized across our sites, both in terms of number of patients, but also in terms of the number of health encounters that we have electronic health record data on. And as I mentioned, each of our sites have taken our electronic health record data, our ICD 9 and 10 data, our CPT data, our lab data, our med data, demographic data, and we've standardized it into the exact same format so that we have a tool that sits on top of our data and we can run the exact same query across all of our sites at the same time. The data still sits at each site, but each site can run that query with the same code because their data is all standardized, both for our 8 data marts in our STAR network, but also for the other 60 data marts across the country. So we have data on 12 million patients, and nationally we have data on about 80 million patients across the country. And many of us have built out linkage between our electronic health record data and other data sources like Medicare, Medicaid, hospital discharge data, private insurance data, cancer registries, genomic data, so we can get much more complete pictures about our patients beyond just what's available within our own EHR systems. The cornerstone of what we do in PCORNet is around stakeholder engagement, and that is true for STAR as well. Every single project that comes to our network goes through a stakeholder engagement review, has to be approved by our stakeholders before we will perform that project, and really has to adhere to the principles of stakeholder engagement that PCORI endorses. So we want to see stakeholders, whether that's patients, clinicians, community members, health system workers that are involved with prioritizing research, with designing the research, with planning and performing the research, with analyzing the results, and with the dissemination phase for results. This is just the types of research we can support: real-world evidence research using secondary data, large survey or cohort studies where we can identify and contact patients and recruit them into surveys or cohorts, and pragmatic clinical trials. We've had over 300 requests come into our network to date and over 80 projects that we've participated in since our inception. So this is a study we did related to patients with coronary artery disease. And at Vanderbilt, we created an algorithm to identify our patients with coronary artery disease that have been seen in our health system and had an outpatient encounter in the last 2 years. We were able to develop a query with very high sensitivity and specificity. We identified 26,000 patients that had an encounter in the last 2 years. And then we were able to contact and survey over 2,000 of those patients in a relatively short period of time. And this, again, really helped us to understand a lot of the social and behavioral determinants about our patients, their marital status, their emotional support, their self-rated health, and other issues that might be impacting their health. And then this algorithm for identifying our patients with coronary artery disease became crucial for a large national pragmatic trial that we just completed, looking at the role of aspirin in treating patients with known coronary artery disease. So we randomized 15,000 patients across the country with coronary artery disease, either a low dose baby aspirin or regular strength aspirin, to see which is better in terms of reducing heart attack and stroke balanced against the risk of bleeding. So, baby aspirin may be better at reducing your risk for bleeding, but may not be as good as preventing heart attack and stroke, whereas 325, maybe is better at preventing your risk of heart attack and stroke, but may cause extra bleeding. So this study really leveraged our informatics. We identified over 650,000 eligible patients across 40 sites. We approached over 450,000 patients, many electronically, and ultimately enrolled 15,000 patients. And you can see a lot of the data was collected on how these patients did with their dose of aspirin by pulling it from the electronic health record and contacting them to collect PROs every 3 to 6 months. So, we're collecting follow-up data with over 49,000 virtual visits. So this just shows you how we were able to pretty rapidly, over a 3-year time period, recruit 15,000 patients and randomize 15,000 patients into the trial. Again, by leveraging a lot of these informatics tools, identifying and contacting patients electronically, e-consenting them, sometimes meeting them at the clinic to consent them as well. We've also been doing a lot of work related to COVID. We have created a registry of over 20,000 healthcare workers into a living registry for the past year, trying to understand how COVID has been impacting healthcare workers in terms of their own risk for infection, stress that they've been facing, family issues, and other factors. We did embed within that a randomized trial about hydroxychloroquine that we launched in a month from March 19th to April. We were able to design, get funding, and launch a large national randomized trial where we ultimately recruited about 1,500 patients and randomized them to HCQ or placebo for prevention of COVID. And now we're doing a study called Hero Together, which is an observational cohort of healthcare workers who have been vaccinated to look at the impact of vaccine on our healthcare workers. This is just some electronic health record data that we have on patients with COVID across 40 of our sites. We have data on about 800,000 COVID positive patients and almost 5 million COVID negative patients that we have deep electronic health record data on. All right, a lot of this work is supported through our Institute for Medicine and Public Health, which Mike mentioned. It's like our School of Public Health, but we've kept it embedded within our medical center, but it supports a lot of our health services research, our Center for Epidemiology, Ethics, Global Health, as well as our departments in health policy, biostatistics, biomedical informatics, and our Office of Health Equity. And we have a lot of training programs and educational programs that really help us to build a lot of trainees and junior faculty to do more work in these broad spaces. So I think I told you it was going to be a whirlwind tour, covered a lot of ground in a relatively short amount of time. But hopefully I've convinced you that population health is a growing field aimed at improving care for individuals and populations. We have a lot of resources at Vanderbilt. I think you guys have a lot and are building more to do this research at UAB. It's a hugely important field right now, a lot of opportunities to advance the science and clinical care for individual and population health, particularly that addresses social and behavioral determinants. And the learning health system or learning health community is really a needed model for embedding this research and really understanding how best to deliver care, not only so that we advance knowledge, but so that we change our healthcare delivery systems to improve care for our patients. So I'll stop there, acknowledge many people, and I'm happy to take any questions in the remaining time. Thank you.
Fantastic. No, thank you, Russell. That was just tremendous. So I think we'll open the floor for questions. Andrea was able to join. I think, Russell, she has maybe the first question. And if others want to either in the chat or raise hands, we can open up for Q&A. We'll get Ken Sag next.
Hey, Russell, thanks so much. That was a great talk. You guys are doing amazing work at Vanderbilt. And I'm curious about your learning health system platform. And I really liked the graphics that you showed and sort of the process and how people navigate through that process. I think you mentioned something like 25 maybe ongoing projects right now. I'm curious about the proportion of projects that are initiated by someone within the health system, sort of specific to a clinical problem versus the proportion that come from investigators or researchers. And as a corollary to that question, sort of how in that process you navigate attempts at external funding. Do people come in with pilots and then apply for external funds, or do they come in with funded projects and then try to engage you guys, and what works best? So that's not super specific, but I guess just talk a little bit more about that maybe.
Yeah, there's a lot of variability. I mean, I would say it's probably 50-50 right now of projects coming from the health system or from investigators. Sometimes it's an investigator that brings a project to us, but a lot of times it may not even be senior leadership from the health system, but it's just like a clinical pharmacist or someone who oversees the specialty pharmacy or someone who oversees like the inpatient physical therapy program who's coming to us with an idea initially. And they're saying, you know, we are thinking about making this change, or we're trying to understand the best way to do this. Can you help us? And there we do find that it can be hard for them to do the project themselves without bringing in some scientific expertise. Like they may not have the design experience to really carry the project all the way through. So we do a bit of matchmaking on the front end, really in both directions. So when the health system folks come to us, we really try to find them an investigator that's going to help them. And we have biostatisticians who can help with a lot of the basic, like, you know, sample size analysis and big design questions, but often they need a clinical content expert who has some research experience, who's going to be able to help them in that idea. And then similarly, sometimes we get things more directly from an investigator, and they have not yet really made the connections to the health system. And so we're doing sort of the exact opposite, and we're identifying the group in the health system to connect them to do that work. It's been a mix of the large majority of the projects we're doing are not coming in with other funding. They really are these sort of 1-year kind of pilot things with some hope that by doing this initial work, it will lead to, I mean, the goal is for it to lead to future funding that they can apply for. Sometimes they come to us and it is in coordination with a grant application, and we're providing them support that goes into that grant application, or or we're at the early design phase. It's not usually that people come to us already funded. I mean, they usually come at the beginning of writing a grant, or seeing a grant that might be a good thing to do with the Learning Health System platform.
Great, thank you. I think Ken, you had a question.
Yeah, Russell, thank you. That was terrific. What a plethora of really outstanding work across your centers there. I'm interested in a design issue. Like you, we've designed a number of behavioral interventions aimed at trying to test ways to improve quality of care, and often find that things don't work. And so the question then becomes was it underpowered, or what? Do you tend to design these as non-inferiority studies to avoid type 2 errors? And if so, how do you look at the data when you're doing comparative effectiveness work around particularly behavioral interventions?
Yeah, oh gosh, that's a great question. We have not tended to fund them, to design them as non-inferiority studies. Maybe we should, right? Because we do end up with negative trials, and then you're stuck with this, are they equivalent, or were we underpowered, or did we have poor intervention fidelity? But sometimes, and I hate to say this, but some of this is also an artifact of PCORI and applying for PCORI grants, where you feel like compelled to have a strong comparator arm, to have good stakeholder engagement, but then you have two arms that are both so strong, you feel like you're heading towards non-inferiority. It is a little bit of a dance, I would say. I mean, ideally, you really want equipoise in your studies, but you have to have some feeling that one arm is going to be better than the other. So I don't think I've answered your question well, other than to say it's very contextual to each individual project, how we navigate that. And a lot of times it's also driven by the stakeholders and what we think is going to be feasible in the two arms. Can we get away with a usual care arm or a quote unquote placebo arm, or do we really need two strong arms for having engagement? And then how much uncertainty do we have in terms of designing, whether or not we're going for non-inferiority or a superiority study. But I would say often we're still designing them as superiority studies.
Great, thank you, Russell. And I realize we're at 1 o'clock, but if I could, just one more really quick question. So the building the platform slides really resonated. And all those 3 or 4 slides with all those pictures of really busy people who already have full-time jobs. So just thinking about any big nugget for us. So as we're on this journey, any big nugget in terms of building the platform when you're crossing these multiple areas with different people. One big take home for us, I think we are on this journey, and would love any big take home you would share with us at this stage of building the platform.
It does take a village. I mean, because there are many different facets to it. I think the two things I would say is one, leveraging existing resources as opposed to trying to reinvent the wheel within the Learning Health System platform. So we do leverage our biostats core from the CTSA. We leverage our informatics core. So, we're not necessarily building everything from scratch. Some of that is leveraging other existing resources across our CTSA or across our, Department of Biostatistics or Biomedical Informatics. And then the second thing is you do have to customize to availability of people's time. So, I showed a lot of health system leadership that are involved, but they're not coming to the weekly meetings. A lot of times they may be coming to the monthly executive meetings, so part of it is is having the right level of people at the right meetings and understanding people's competing interests, and asking them to commit the right level of time.
Yep, great. No, thank you. That's wonderful. So realize we're a few minutes past. I want to thank folks for joining and for staying on. Russell, thank you for staying on a few minutes and for sharing so much with us today. For the UAB folks, please come back and join us next week. We're going to have an internal look at a pressure injury example of learning health system work that's been done at UAB. And I hope everyone has a great day. And again, Russell, it's great to see you and really appreciate you sharing with us. Take care.
Yeah, great to see you guys. Bye-bye.